it should inflate, deflate quickly. When you press, it should pass the impulse. We should feel the impulse here, and then there should be a safety valve mechanism which should be operational. For example, if I press it, now you are not getting the noise of this safety valve. Now you are getting the noise. That means I am giving a higher pressure. And the best guide that what pressure the baby requires is either there should be an increment in the heart rate or there has to be movement of the chest wall. The first parameter which you assess is the rise in the heart rate, and how much it has to be seen, how much pressure is to be given, that you assess by how much chest wall you are able to lift it. You see as if the baby is breathing normally at a rate of 40 to 60 per minute. That also I will tell you how you can assess that baby is breathing at a rate of 40 to 60. One thing is the mask. Which type of mask you utilize? There are two types of mask. Okay, the circular mask and the anatomical mask. Okay, it is the circular cushioned mask which we utilize for the neonatal resuscitation. Now, how should we find out the correct mask size? This mask should cover the chin, mouth and the nose. You can see chin, mouth and the nose. This is the correct size of the mask. If I see this, if I use the smaller one, the nose is not covered, right? And if there is a bigger size mask, then it will cover the eyes also, which we do not want. It will hurt the eyes. So the correct size mask, for example, for this baby, you can appreciate chin, mouth and the nose. Okay? Now, having learned the indication, now having learned the parts of the equipment, and we will now actually go into the process of the positive pressure ventilation. And as it was shown you by Pratima, that for term babies, we have to initiate the resuscitation with 21% oxygen. That means I will take this bag without oxygen, right? I have used this correct size mask, and this is my position. Position of the person who is providing the positive pressure ventilation is the head end or side end. So I am using the head end position because at one time you will see somebody has to give the chest compression, so you have to make the way for the other person. So I am using the head end position, and this is how you will keep the mask with the thumb and the two fingers. Apply firmly on this, right? And you give the positive pressure ventilation to have the easy movement of the chest wall. Now you see the movement of the chest wall. Can you appreciate? Now we have to give at a rate of 40 to 60. So you say squeeze 2, 3. See that? Squeeze 2, 3. Squeeze 2, 3. Squeeze 2, 3. Squeeze 2, 3. This gives rate of approximately 40 to 60 per minute, as if the baby is having easy breath. Squeeze 2, 3. Squeeze 2, 3. Do not give this pressure. She mentioned very important point in the initial steps. You reach the labor room 10 to 15 minutes prior to the expected delivery. See your things are in order. Read the obstetric records. Equipment is functional or not. Your laryngoscope is working or not. Tomorrow there is no point in blaming each other. Nurse, you have not done this thing. She will say, you did not check. It is important for all of us. Stop blaming each other. Let's do our own job. And anticipation is the most important thing. Once we have done this, you have given the positive pressure ventilation. Give it for 30 seconds. 30 seconds she talked about the initial steps where you did the assessment. That means you saw 3 points and you took the action on that. You dried the baby, you did the suctioning and you stimulated. Next 30 seconds you provide positive pressure ventilation. This is known as the golden first 1 minute. Golden 1 minute, where you do the assessment, provide the initial steps if they are required. If the baby fails to initiate respiration, provide the positive pressure ventilation. And each cycle is of 30 seconds. After 30 seconds of positive pressure ventilation, the way I am doing it, you again assess. After 30 seconds of positive pressure, you will find that many of the babies, they have started breathing. Someone is also checking the heart rate. Heart rate has picked up. If the heart rate is below 100, but the baby is breathing well, you continue positive pressure ventilation till heart rate also goes up. Once the heart rate goes up above 100, the baby is crying vigorously. You see the color of the baby. Whether the baby's color is pink or the baby is having persistence of the cyanosis. Because you saw the target values which was shown. In the first few minutes, you don't have to achieve the saturation values of above 85% or 90%. That's the saturation, the baby is already tuned to that. First few minutes saturations are less. So at that time, even if the baby is having slight lower in the saturation of 65, 70 in the first minute, second minute 70 to 75, and by 5 minutes, the baby should have 85% saturation. That's the target values you should keep in your mind, and that chart should be there in the labor room. After 30 seconds, I have seen the heart rate. Now there are 3 scenarios which I am going to have it. 1, the heart rate below 60. Another, heart rate between 60 to 100. And 1 above 100. That will tell me my decision, what I have to do, what action I have to take place. As it was said in the physiology, that if the hypoxia is prolonged, then baby enters into a phase of secondary apnea, the heart rate dips and the blood pressure dips. You have given the positive pressure ventilation, and if the baby fails to respond to positive pressure ventilation and the heart rate is still below 60, that means cardiac output is low. This baby will require external cardiac massage. External, so chest compression is nothing, but it is an external cardiac massage. Okay, so that is the one scenario. Second scenario is when you have the heart rate 60 to 100. This is usually a transitory period. You will find the baby will either move to 100 side or the baby will move to 60 side. It's a very short period. But if it is below 100, you have to continue positive pressure ventilation for next 30 seconds. Now, if you do not find with 90 seconds of positive pressure ventilation with room air, that means this baby will require supplemental oxygen. You have to enhance the saturation, the oxygen concentration. the best way to enhance the oxygen concentration is that you should have a blender, so that from 21% you make 30%, 40%. But most of the places you will not find the blenders in the labor room, even in the best of the medical colleges. So what should I do? I will attach the oxygen without reservoir. Now what this is going to provide? Roughly 40 to 50% oxygen. So if after 90 seconds the baby has not responded to 21% oxygen, then I will give the supplemental oxygen and give it this 40 or 50%. Try for next 30 to 60 seconds, baby does not respond, attach the reservoir, you will provide 100% oxygen. Is that okay? And then you evaluate with 100% oxygen of 30 seconds. If the heart rate is below 60, with good effective ventilation, if the heart rate is below 60, go for chest compression.
So, if it's an emergency situation, then can you give mouth to mouth? Like baby ko mouth to mouth de sakte agar hai nahi humko bag ye resuscitating bag?
Yes, there are some alternative devices, like as you mentioned, mouth to mouth, or sometimes they have mouth to tube or mask to tube. You attach a tube here, just like you have a child's balloon where you blow it and then balloon inflates. So similarly, that kind of the concept is there, that you attach a tube here, apply to this and push the air through that.